Karnataka Neonatology chapter. We would like to give a very, very warm welcome to you, sir.
Thank you.
And today's session is a very important one. We have advances in the diagnosis and management of neonatal laryngeal disorder. So this is what we see post-extubation or when baby is born with certain laryngeal congenital disorders. What are the things which we need to do as a neonatologist, and what are the options available for a baby to get treated or to get cured? So this is what we're going to have a discussion today. So today's session will be moderated by Dr. Abhishek Patke. He's the chief neonatologist at Indiana Hospital, Mangalore. And today's session, Dr. E V Raman sir is a chief consultant ENT surgeon in Manipal Hospital. He's the head of the department over there. It is always pleasure to invite you, sir. I request you to start the session. Over to you, sir. And I request you to give a brief introduction about the things what you have done, sir, and then we can start the session, sir. And I request all the participants to kindly mute. And since we have shifted from Zoom to Microsoft Team, to respect our Indian soldiers and our commitment towards trying to boycott China and Chinese products. So this is the first step. So this is the first webinar we are doing through Microsoft Team. If there are any hiccups, please forgive us. Since we are also learning with this, probably with 1 or 2 sessions, we'll be able to master this. And I humbly request all the participants to kindly mute and mute your both audio and video so that the session is not interrupted. Because E.V. Raman sirs, we have heard earlier also, you will love his talk. He has got that mesmerizing effect on all of us. He's really good. We should not disturb him. We should just sit and enjoy his talk. Over to you, sir.
Good evening. Thank you very much for inviting me. It's always a pleasure and honor to be with the neonatologists. One of the reasons is that they run my kitchen. All these years, referrals from them is what has made me sustain myself. But apart from that, going to today's talk, the task given to me is basically advances in the diagnosis and management of neonates with laryngeal problems. Let's see whether we can get the slide on. Here we are. Without sounding very egoistic, I think your choice of the speaker is appropriate and apt, because I was a medical officer in the Indian Air Force, and I've had the pleasure of working in Leh for a short period of time. And your patriotism and nationalism touches me, and I think we should continue to do what you've initiated. Now, coming back to today's topic, we are talking about the advances in diagnosis. And without diagnosis, of course, we can't management of neonates with laryngeal disorders. What is it that has led to this advance? I think the single most important factor that has led to this advance is better understanding between neonatologists and the stakeholders. Unless we understand and speak the same language, we can't have any benefit of any advancement. And I think this interdisciplinary communication.
Raman sir, slides are not there. Raman sir, slides are not there.
Slides are not being seen?
Share the slides.
1 minute. Oh, it's being seen in the people sitting with me. They're able to see.
Yeah, slide
Yes,
is
sir, you have
visible.
to share that slide.
It's coming through their mobiles.
Okay, sir. Continue, sir. Then continue.
Okay, right. So as I was saying, the advances, one is better understanding between the two specialties. Second is the fact that we can make a precise diagnosis now. And once your diagnosis is precise, the treatment can be absolutely customized for that particular patient. More important than that is timely diagnosis. So unless the neonatologist and the ENT understand what each other can do for the benefit of the patient, if the treatment is delayed, that advancement does not hold good. But what is a single thing which has really made diagnosis and management better? That is the flexible fiber optic, nasopharyngeal laryngoscopy. You can also add bronchoscopy because we also see the lower respiratory tract when we do that. The availability of telescopes, the availability of excellent anesthetics and anesthetists and anesthesia, and finally, the evolution of the surgical options that are available. And more important than that, as you gain experience, you know when to operate and when not to operate. Beginning with these things, let's go into the nitty-gritty of today's talk. And what we have here, what is our concern when a child comes to us? The concerns are the noisy breathing that the child has got, the respiratory concerns, that is the stridor, snoring, inspiratory or expiratory or biphasic. And then we also have the voice, that is whether the voice is hoarse, breathy, muffled, or normal. Then we have the feeding issues, where it could be difficult feeding, drooling of saliva, and normal, whether it's normal or not, and then choking. So this gives you a hint of what we are dealing with. And finally, we must remember that the respiratory tract starts from the nose and it doesn't start from the larynx. So we need to look at the nose, the oropharynx, the supraglottic, glottic, subglottic, and the tracheal areas, which are the subsites. And finally, of course, the retractions, whether there's no retraction, whether it's suprasternal, intercostal, substernal, subcostal retractions. With these things are the initial observations in the directions in which we need to work on. Now let's look at the laryngeal lesions per se. On the left side here, you can see that you have the area which produces the inspiratory stridor. That is the pharynx and supraglottic area above the vocal cords, which usually produces an inspiratory stridor. And you have the vocal cords, which is the vocal watershed, where you have the biphasic stridor. And lower down, all this is biphasic in the cervical trachea, and where the glottis, subglottis, and cervical trachea, all three. And lower down is your trachea, thoracic trachea, bronchi, where you have the expiratory stridor, and you're experts in it. I don't have to talk about that. Now, what happens in the supraglottis? Let us see it subside. The commonest one is laryngomalacia, which you are aware of. Then you have laryngoceles, and then we have stenosis in the supraglottis, which could be due to intubation-related injuries. It could be vascular malformations, neck masses. Then you come to the glottis, where you have vocal cord paralysis, intubation injuries again, because the kind of emergency intubation and intubation for long periods of time, etc., etc. Then you have laryngeal clefts, which is often missed and not diagnosed, glottic webs. Then we have stenosis in the glottic area, laryngeal trauma and fractures. Then, of course, the children do not come to us directly with typical airway problems, but may come later with croup or intubation granulation and edemas, acquired stenosis. Then you can have hemangiomas in the subglottis, cysts, congenital cricoid malformations, and foreign bodies. So these are the various sites from where you can get the stridor, and these are the commonest causes of the stridor. Now, how do you evaluate these patients? They all come with the same symptoms. Now, you have a plethora of diagnosis you can choose from based on your evaluation. And as usual, clinical medicine always starts with history, and we have to find out when the symptoms were initiated. Was it soon after birth? Was it about 2 weeks after birth? Was it about 2 months after birth? Or even later? Usually around 2 weeks later after birth is when patients come, or at least a week after birth is children with laryngomalaccias. They don't manifest soon after birth. Soon after birth is the other congenital problems. Then you have other cases where around 2 months you can have hemangiomas starting producing symptoms. So it's important when the symptoms are initiated. Second is duration of the symptoms. How long has it been on? And whether it's episodic or is it continuous? And is the symptom steady? Is it improving or is it worsening? Any associated weight loss or failure to thrive? And then are there associated feeding difficulties? You have to question these, the parents, and get this information, which is very important. Has there been an intubation history? Any prior surgeries the child has undergone, and any neurological conditions which have already been diagnosed, and then syndromes and genetics, which gives an entirely different kind of prognosis to this condition. So what are the investigations? We go back to the awake fiber optic nasopharyngeal laryngoscopy. It's a beautiful investigation. It gives you the dynamic, real-time visualization of the airway, which we were missing when we were using rigid instruments. It's fairly safe, it's fairly simple, and is of great benefit in diagnosing laryngomalacia, vocal cord paralysis, laryngopharyngeal reflux, screenings for subglottic stenosis, and subglottic hemangioma. The moment you do this, you get an idea. Mostly your diagnosis will be 60, 70, 80% accurate. There are very few conditions you would miss by doing only a awake fiber optic nasopharyngeal laryngoscopy. This is where you get the yield, maximum yield as far as the investigations are concerned. Of course, sometimes you may have to resort to airway radiographs, which are most useful when there is a croup. Again, you know about these things. They are typical exam questions with the steeple sign, epiglottitis with the thumb sign, and tracheal stenosis you can see, and then complete tracheal rings can be suspected if there's a narrowing of the trachea right from in a large part of the trachea. Airway fluoroscopy for dynamic lesions can be done for tracheomalacia, but these are all secondary. And then you have CT for evaluation of the airway, especially if you're planning some surgical intervention or if there's an extraluminal obstruction. MRI is for neck and chest masses or aberrant vasculature. Now, what we learned from this single slide is one, it is awake fiber optic nasopharyngeal laryngoscopy. And I'll say that a number of times, 4 times, 5 times, that is the most important investigation. Everything else is supplementary, and that's the most believable investigation. And I'm also very concerned in these small children with their surface area being so small, they're exposed to so much of radiation in the CT suites, and the problem of taking these children with airway problems into the MRI suite where you can have an acute crisis. So, and then airway fluoroscopy again is a fair amount of radiation and the yield is very poor. There's one exception. That exception is if you have done the awake fiber optic nasopharyngeal laryngoscopy and you're suspecting an external compression, yes, by all means, do a CT or an MRI to confirm the diagnosis. But a better way of confirming diagnosis for all the problems, especially the intraluminal conditions, would be an examination under anesthesia with rigid scopes and telescopes. Now, getting back to the indications, when do you do the fiber optic nasopharyngeal laryngoscopy? This has been the question asked by a lot of my pediatric colleagues. Do we send all patients to you? How can we do that? How do we arrive at a conclusion? So you can see in the picture on the right side, the child is a very small, low birth weight baby. And here oxygen has been delivered through this mask kept at a distance. This is the fiber optic scopy. And a couple of people are helping me here. The child is not under any anesthesia. This is an awake, flexible laryngoscopy. Now, if there is severe stridor, yes, please go ahead and do it. If there's progressive stridor, the stridor is increasing. Next one is stridor associated with unusual features. And what are they? You have cyanotic attack, you have apneic attack, you have dysphagia. So these are all indicators that you must get the child screened if there is aspiration and then failure to thrive. Then there is one more very important thing is when there is a radiological abnormality. Already you've done the X-ray or a CT or something and you want to check out, yes, you can go backwards and do a fiber optic nasopharyngeal laryngoscopy. Finally, there are cases which come to us with parents saying that the child is rising breathing. I don't know when the child is going to stop breathing. So you can't sleep at night. Can you just make sure that nothing is wrong with my child, which requires treatment emergently? So very rarely you need to do this also. So those are the indications for fiber optic nasopharyngeal laryngoscopy. Now, how do we go about these things is what I need to show you. And why do we do this? We have to get the proper, precise diagnosis because many of these conditions are self-resolving. You don't have to do anything. It's just careful watching the child and it becomes all right without doctor, without much of medicine. But there are some conditions which are medically treatable. There are some conditions which require renal intervention surgery. And there are conditions where simple open surgery is required. And then there are complex open surgeries too. So to get the right fit, you need to really assess the problem, define the problem, grade the problem, and decide when to intervene. Now, The challenge is to decide on the course of action. One is based on history, which we have already finished. Now we choose further investigations if you need any, decide on the diagnosis, and initiate the management. Now, in this particular case, just because my pediatrician colleagues have such wonderful CMEs which I've attended, and they always involve the audience. Unfortunately, we are on a webinar and not a face-to-face contact, but we need to see how I can at least get you involved a little bit. So I'm going to play this sound. So you find that the inspiratory sounds here. So this one is better. Sorry, this sound was, yeah, listen to it again. It's a low-pitched vibratory sound that you're hearing. This comes from the uppermost part of the upper airway. That means the nose and the pharynx. So let us see this video. So this is akin to snoring, and the collapse is occurring either in the nasopharynx, the pharynx, or there's a nasal obstruction. Not much of retraction in this particular child, you can see. So you have to differentiate between stertor and stridor to start with. So we go to the next slide. So what are the definitions in anatomical divisions which cause? See, stertor, I already told you, snoring, nasal airway, we won't spend more time on it. Stridor, upper airway, supraglottis, glottis, subglottis, trachea. And wheezing is, of course, I'm not going to talk about it. I'm not an expert on that. Let's listen to this sound. So the inspiratory sounds are much more. So it's mostly inspiratory. And what are the conditions which cause this? Here we have. The sound is slightly low volume, but it's totally inspiratory. It is important to see the child, see the retraction, time the retraction. In fact, in our mind, we'll say inspiration, and then you hear the sound. Inspiration, hear the sound. Inspiration, you hear the sound. So you time the sound to the phase of the respiration. In this particular case, this is probably a suspected laryngomalacia. Just playing it once again for your benefit. Okay, now we have one more condition here, which I want you to hear the sounds. This is inspiration and expiration. This is a biphasic stridor. So we told you that anything in the vocal cord level and below could produce a biphasic stridor. But one rule is there, whether the problem is in the supraglottis, whether the problem is in the glottis or lower down, if there is a fixed obstruction, it could produce a biphasic stridor. One must remember that. So we just go to one case scenario, 2-week male child with noisy breathing since birth, increases when feeding and lying supine versus sitting upright. Nursing takes a long time with frequent needs for breaks and gagging, spits out after every feed, no apneic spells or cyanosis. And otherwise, the full-term uncomplicated delivery, otherwise healthy. So let's see what this is. So this particular child, suprasternal, subcostal retraction, you can see. And I'll play the sound here. And this was noticed when the... This was noticed when the child, more when the child was feeding. So we normally evaluate the child not only when the child is awake, when the child is crying, when the child is sleeping, and when the child is feeding. When they mute the mics, a lot of background noise coming, if I may say so.
Yeah, Singh, kindly mute all and then only unmute this thing. I think few of the mic is muted. Singh, mute all, and just put V Raman sir. Sir, you can unmute yourself, sir. Mute all.
I am doing so.
Yeah, can you hear me?
Yeah. Yes, sir. You can start your PPT, sir.
You can unmute and start, sir.
Already I have unmuted, sir. You can start.
V Raman, sir, you can unmute and start continue the presentation, sir. You can unmute yourself. Sir, you are able to unmute?
Yeah, done.
Yeah, please continue.
Yeah. Sorry about this interruption. So we are going to talk about laryngomalacia in some amount of detail because it's a commonest cause of stridor in infants, almost 75 to 80%. The average age of presentation is around 2 weeks. I told you what time of life the child present to you is important. It's a high-pitched, fluttery, inspiratory stridor because of the collapse of the supraglottic area, because various theories are there about why it happens. It gets worse on feeding, on agitation, and supine position. Now, there are feeding problems in almost 50% of these children. And if you do a swallow study, it's abnormal in 2/3 of them. And sometimes the problem may be abnormal even without overt signs of any aspiration. And in 2/3 of the patient, there is gastroesophageal reflux symptoms, but we do not know whether it's a cause or the sequence, which we shall discuss in a few minutes. 8 to 45% of these patients do have neurological conditions. Hence, the incidence increases with disease severity. And later, if this is not attended to, newer papers talk about obstructive sleep apnea, easy to understand in 60 to 80% of these children. They may not have too much of stridor, but they may have obstructive sleep apnea. So you must keep track of these children who come and you think it's going to resolve, but land up with sleep apnea related issues. Now, regarding the pathogenesis of GERD, now there is respiration in laryngomalacia, which is going on against a fixed obstruction. Then we have, because of that, a large negative intrathoracic pressure. The negative intrathoracic pressure results in reflux into the esophagus and results in laryngopharyngeal reflux, which causes laryngeal edema. And laryngeal edema causes increased prolapse of the suprastructures in the supraglottis. So then what happens, there's increased obstruction, and this is a vicious cycle. It goes on, and one thing making the other thing worse. And then you have a child with much more increased symptoms as time goes on. So now we come to the flexible fiber optic laryngoscopy, which is done away in, we do it mostly in our pediatric emergency room. And you can see that the child is undergoing transnasal, and then a child is awake. We just hold the child, keep monitoring the child's oxygen, and this is a little bit of oxygen supplement here. And we also sometimes give non-nutritive feeding. That is, we keep a gauze soaked in some dextrose so that the child is quiet, and then we can observe the quiet breathing of the child. If the child is continuously breathing, again, crying, it's difficult to assess. So it should be kind of quiet breathing. Or sometimes we also resort to a little bit of sedation, very minimal sedation, so that you can see when the muscle tone goes down, what happens to the breathing. Now, these are some pictures to explain to you what actually happens. And this is the epiglottis. And this is the arytenoids, the short aryepiglottic folds. You see, this is directly connected here, and it's like a hood here. And every time the child breathes, it completely closes, and sometimes it closes for a long period of time. And we are examining the child with a telescope here, and this is the tube, endotracheal tube, which is kept in the nasopharynx, so that we can take a picture for a longer time. This is the what's happening here without any muscle relaxant being given. We are observing, this is just before the surgery to confirm the child requires the surgery or not, because you need to decide what kind of surgery to do, because various types of supraglottoplasties. So let's see this also here now. So you can see that completely closes at times. Yeah, that's it. So there are two types. One is when there are curlers. Curlers means the epiglottis curls on itself and blocks the area. And there are floppers. In this case, both is happening. The arytenoids are falling forwards and the epiglottis is curling on itself. So curlers and floppers, and depending on that, we decide what kind of a surgery is to be done. Okay. So what is the management? You all know about it. It's watchful waiting. Most of these cases resolve by 18 to 24 months of age. But during that process, you can put them on anti-reflux medication, either H2 blockers or proton pump inhibitors over a period of time. And it has shown to have fair amount of, not 100% evidence, fair amount of evidence that at least it helps the children tide over that initial period. And once the laryngomalacia resolves itself, then you can wait for a little longer time. Now, but then there are some children who land up with surgery. Now, our job is who are the ones which will land up with a surgical option. Now, what is the percentage of infants with laryngomalacia who have severe enough symptoms that require surgery? The numbers vary depending on the kind of practice that you have, but basically it used to be 10% for a very, very long time. And now it is coming towards 20 to 25%. The reason being that the wonderful work you neonatologists are doing and the antenatal checkups and the fetal medicine people, children would have otherwise died or surviving, and then they land up in NICUs. And these children are adding to the bulk of the laryngomalacia children, and hence the numbers are going up, especially in tertiary care centers. In our own personal series of very few cases, which we did in the last 18, 20 years, we don't operate on all of them. Even then, the percentages come up to almost 35% because of the referral patterns that we are having. So roughly across the board, I would put it as 20% will require surgical options. Now, what is the surgical management? It is supraglottoplasty. What you do is, I showed you the pictures. We release the aryepiglottic folds, trim the redundant arytenoid tissue, and do an epiglottopexy. Now, I'm going to describe it later with some pictures. Here we have a video, and this is the epiglottis, and this is the scope, and this is the laser-bearing wand. We use the CO2 laser, which is the kindest laser as far as the larynx is concerned. And we are using it in the fiber mode, which makes the laser much more expensive. And here we are. You can see this is the aryepiglottic fold. And here we are using the laser and in a super pulse mode. And you see that it just frees up. It just opens up. And with minimal scarring, minimal carbonization or charring. So you just should not burn the tissue. It's very important. And we are just removing the charring. And is that the only way to do it? No. The cold cut methods are equally good. So we'll just show that to you. I hope it works. Yeah, I'll just move it faster. Here we are. So you see the cold cut instrument. Cold cut instrument is the cold steel. And you see the aryepiglottic fold on the other side. And we have this scissor here. You can see that. And this is the vocal cord here. And the most important thing is we are doing it without any tube in the larynx, because we've got extremely good pediatric anesthetists who've learned on the way, both of us, we learned from each other. And that's it, hardly any bleeding. So cold cut is equally good. If somebody says, I can't do an aryepiglotoplasty because of ABC reasons, because I don't have a laser, that's not true. And so you have the same results with either of them. So that is one myth which has been broken, because sometimes advancement does not necessarily mean that you need to have costly instruments. So here is a patient. Unfortunately, the volume in this case has not come up. So this was a child preoperative. You just see the retractions here, suprasternal, intercostal, and substernal retractions. And it works almost like magic, a simple surgery. And here we have the postoperative. And you see absolutely no retractions. This is 24 to 48 hours. This picture has been taken by my pediatric pulmonologist. So it's wonderful experience we have. So now what are the absolute and relative indications? Now we have to know this. there are some absolute indications for supraglottoplasty. Now, supraglottoplasty is an umbrella term. You can just snip the aryepiglottic fold, like I told you. That is called aryepiglotoplasty. Then you have what is called as the epiglottoplasty, where we go and stitch the epiglottis to the base tongue, or make a laser cut there so that it goes and falls forwards, or you can put a stitch. I've hardly done that. And the simple aryepiglotoplasty and removing the redundant tissue has helped me most of the time. Now, the indications, cor pulmonale, yes, we've seen cases with cor pulmonale if it continues for a long period of time. Pulmonary hypertension, hypoxia, apnea, recurrent cyanosis, failure to thrive over a period of time, pex excavatum if it continues longer, stridor with respiratory compromise, stridor with significant neck-chest retractions. So these are all for indications. Now, relative indications will be over a period of time. You think a child will improve. You watch a child month 2, month 3, month 6, and then you find that the child is having some aspiration problems, difficult to feed, and then who has failed medical intervention or weight loss with feeding difficulty. This could manifest later because as the metabolic demand, the caloric requirement increases and the child is being fed more, at that time you can have more aspiration, or also because the work of breathing the child doesn't really put on weight. But then it's very difficult to convince some of our patients who are well-bred that there's a need for surgery because they think the child is very, very small. So there was this wonderful study by David White who compared adenoidectomy with supraglottoplasty, and what are the results you get in each one of them. 85% of them get better, 60 to 85 in adenotonsillectomy. It's no more risky, or probably even less risky than tonsillectomy. That was the aim of this study. And this is just for awareness for our neonatologists to say this is not a very risk-taking surgery, and it can pass off as a regular routine surgery. But there are other supraglottic anomalies. You can have supraglottic webs, which are relatively rare. You can have anomalous cuneiform cartilage. Then you have a bifid epiglottis, especially in association with the Pallister Hall syndrome, where you have this hypothalamus hematoma, polydactyly, syndactyly, and laryngeal findings would be a bifid epiglottis. But then when you hear the child's breathing sound, which is an inspiratory sound, you would think it's again a laryngomalacia. So my friend Dr. Bilagi the other day gave a talk on how all sounds are not laryngomalacias. He's attending the meeting today. So he says it's a dumping ground diagnosis. You don't know what's happening, you call it a laryngomalacia. Be very cautious about that. So let's see this case here. So there you are. You have a bifid epiglottis in this Pallister Hall syndrome case. And you also have laryngomalacia here. That doesn't mean, that's secondary to this obstruction. And that's the vocal cords here. And let's have another view here. And you can see this is the epiglottis there. And then we're using what is called as we're using a forceps to just separate that and see how to suture this area. And after suturing this area, this whole area becomes tighter. So we went and did an aryepiglotoplasty and released that. And we put a little gum here. I'm racing through the slide because we have a lot of other things to discuss and not the details of the surgery. The surgery has been done here. You can see the sutures. And now you see it is closing, and the laryngomalacia will become worse in this case. So we need to go and do a aryepiglotoplasty there to prevent this collapse. So some other pathologies. Now we have the supraglottic cyst here. And this is because of the closure of one of the many glands, because you have glands right through the upper respiratory tract. This is just sitting somewhere near the epiglottis in this area. They had a problem of intubating it. And you believe it or not, this was many, many years back, almost 18 years back. And this child was flown by my neonatologist, Dr. Karthik Nagesh, all the way from Coimbatore. And these days, I'm sure there are enough ENT specialists who understand these things better, but these were the early days. But then you can have cysts at other places because the larynx is full of glands. And this is a case where you have the cyst in the ventricle area here above the ventricles. And this is the entire skin there. And we are decapping the whole thing. That is the epiglottis popping out. And it was good old days. Our anesthetist insisted those days on an endotracheal tube here. And I was also a novice. It was learning time. We didn't want to take any chance. But today, if I were to do it, I'd do it with a tubeless anesthesia because our anesthetist learned along with us, and they are so good that without them, I cannot do any of these operations. And so this whole thing is marsupialized. And once the whole thing is marsupialized, it's like an open saucer. You can see that these are the vocal cords and beautifully done here. Um, so that's so then you have much more severe problems like the laryngeal atresias. And the most severe process is one where there's failed recanalization. It is always present at birth. So I told you at birth, you can have these problems. 2 weeks after birth, you can have laryngomalacia. 2 months after birth, maybe you can have those hemangiomas. So it depends on the time of presentation. Although on an average, our laryngomalacia patients land with us for definitive surgery between second month and the third month, unlike what's described in the books, because there is some time to convince the patient and for them to reach the person. And laryngeal atresia will require a laryngotracheal resection, reconstruction. So this is non-canalization of the larynx. These are the vocal cords, and you see that there is no introitus at all. And then that's what we thought. And then posteriorly, as we saw the examination, and we found that there was an opening here. The opening was much smaller. You'll see it in a few seconds. Yes, the child was breathing through this. This has been dilated. And so this is a plug of tissue right through, and there's a non-canalization. It's one of the most severe forms of the web. And these children have a lot of problems. And this child came to us from Calcutta, I remember. And here we are. Yeah, that's this one. So we said we are masters in this. We saw another case who came from Goa. This is the vocal cords here. And we said there must be a small hole here. That's how the child is breathing. There was nothing here. And this child had a tracheostomy done 6 hours after birth by a pediatric surgeon in Goa. And then they contacted us and came to us. And how did the child live till that time? The child lived till that time because the child had a tracheoesophageal fistula. So sometimes they give you time, but then in the process, you can have some amount of CNS damage. We operated on this child successfully, but unfortunately, about 2 weeks later, we lost the child because the child had obviously some CNS-related issues which happened. So you must be very careful in choosing the kind of a patient. But in this case, everything went off well. But after 2 weeks or so, the child had a vomit, choked, and expired, unfortunately. So these are very rare cases. Now, if these children come to me today, or if they had come to me in the year 2009, when we started doing what is called as our exit procedures, we probably would have let this child live and tell you a story. So what is this exit procedure? Extrauterine intrapartum therapy. This is teamwork. This is not the ENT surgeon's work. It's the work of multiple people sitting together, deciding what to do. It is almost like the war room where we sit and decide what is to be done, who's going to do what at what time. And the theater is like a hawker's market with all the telawalas sitting there and trying to sell their wares. So let's see what exit procedure is. I told you it's extra-utero intrapartum treatment. It's an extension of the classical cesarean section. The cesarean section is done, the baby is delivered, and it remains attached by the umbilical cord to the placenta. Once the airway is secured and the umbilical cord is cut and the infant is fully delivered, then you secure, once airway is secured, your job is done. So we published this in 2009, many years back, and we did this case probably in late 2007. And we have about 6 or 7 cases now. And it's an established procedure, and there are specific indications for this. And it's all, there has to be a meeting, and you have to decide whether this is the right option or not. Because these days, to do new procedures, sometimes some of us get carried away and do these procedures when it's not absolutely indicated. Not that we are morally much higher than the others, but we have to exercise caution as surgeons and as physicians, where we don't want to do something because we know how to do it, but it should be what the child needs.
Video is lost.
Sir, EV Raman sir, are you there?
No video audio. Nothing.
Singh, can you mute all and just unmute EV Raman sir?
I think we lost the connection with EV Raman sir.
Can't see EV Raman sir.
He's joining back. Give us few seconds. He's joining back. I think he lost the connection. In few seconds, he'll be joining, sir. Yeah, sir has joined now. He will resume the talk. Sir, EV Raman sir. Yes, sir. Yes, sir.
You couldn't hear me for a long time?
Yes, sir. Yes, sir. Because we had lost the connection. All of us. So you can start from evolve indication of exit procedure.
Okay, I'll just go back. Yeah, good.
Yeah.
Just a second, I'll go back to that slide.
Yes, sir. Yes, sir. Singh, kindly mute all. Let only sir get unmuted. You can start from evolving indication of exit procedure, sir.
Yeah, okay, good. Yeah, that's it. So I've already told you about the evolving indication. Basically, it is for the prenatal diagnosis which has been done when there is high airway obstruction, congenital airway obstruction, and so it is this isogenic prenatal tracheal occlusion or congenital diaphragmatic hernia is when you put a balloon in the lower end of the trachea, and over a period of time, as the secretion collects, it allows the lungs to expand, and when the child is delivered at that particular time during the exit procedure, what you do is the job of the ENT specialist is to remove the balloon from the trachea. So that has to be done within about 52 minutes time you have. And then the child is connected with the, through the placental circulation is still going on during that time. That acts as the heart-lung machine for the child. So that's a time you have. And also done for extrinsic airway obstruction, large fetal neck obstruction, and I told you about the congenital high airway obstruction, oropharyngeal mass, and then unilateral pulmonary agenesis. I'll just rush through these things as I think we must have lost some time. So what is congenital high airway obstruction? It's diagnosed by antenatal ultrasonography. There's a dilated trachea, bronchi, distal to the obstruction, enlarged echogenic lungs, diaphragmatic inversion is there, and presence of fetal ascites, fetal heart is displaced to the midline. So this is a prenatal diagnosis. It could be iatrogenically produced like we did when we put a feto. Feto is a fetal tracheal obstruction balloon in the child who had a congenital diaphragmatic hernia, or it could happen due to various other congenital problems which is obstructing the airway. So you diagnose the condition and then you plan for an exit procedure. So the next slide, this is how the, of course, conventional cesarean is done. I am not putting up the video because of the shortage of time. And
sir, can you restart the slide presentation, sir? It is stuck at one slide.
okay, we go back.
Yeah, just stop sharing and then start sharing again, sir.
Yeah,
with the
sure.
same slide.
It was done.
Is that okay now? Are you able to see the slide?
No, sir. The slide is stuck at one evolving indication only. Stop sharing the slides.
Stop.
It's moving for me.
We are unable to see, sir, the slides.
I'll be just reorganizing. Give me a second.
Can you see now?
Can you see now?
Yes,
Still-
yes.
Yes, sir, we can
Yes.
see now. Yeah.
Okay. You
Yeah,
can see now?
we
Yeah.
can.
Yeah.
Yes, yes.
Yeah. Please go ahead, sir.
So did I describe the slide earlier or should I go ahead? Hello?
Please
Sir,
go ahead.
go ahead,
That
sir.
was. Go ahead, sir. Go ahead, sir.
Okay. So this, I think I already described quickly. I'll tell you, this condition is caused congenital high airway obstruction syndrome is due to some block in the airway at the laryngeal level or lower down. And it's diagnosed by the ultrasound antenatally. Dilated trachea, bronchi, distal to the obstruction, enlarged epigenic lungs, diaphragmatic inversion or flattening, presence of pericarditis. Fetal heart is displaced to the midline. Once the diagnosis is done, when you plan for the exit procedure, it's actually cesarean section, but not some people understand the is still connected to the placenta, to the umbilical cord. So you have time to restore the airway. So in this particular case, the child had a cystic hygroma, and there are various options. You can try to intubate directly or use a video laryngoscope and intubate as is being done in this case. And in case that is not possible, you have to use a bronchoscope and use it as a ventilation port. Otherwise, if that is not possible, you have to do a tracheostomy within those 52 minutes. And all this has been decided in short period of time by the team of doctors. And this is called the exit procedure. We have been lucky to perform about 6 or 7 of them. And we have started the first case was in 2008, I think. And so that's an option. This is the child with the tube inside. And you can choose to excise the mass immediately or later, depending on the your expertise and the availability of the support systems. So we go to glottic abnormalities where there is vocal cord paralysis, the second most common cause of stridor. 10 to 15% of the laryngeal pathologies. It could be unilateral or bilateral. It could be due to vagus nerve damage, and it could be idiopathic or due to hydrocephalus, trauma, cardiac problems, etc. And so in this particular case, you can see, I'll just show you an example of the sound that you get. So here, bilateral vocal cord palsy, and that's stridor, which you're getting, biphasic. And here is the symptom being confirmed with a telescope. And so the child should not be given any relaxant, and you must observe it and then decide on definitive treatment. Many of these cases do become better over a period of time. Some of them require certain procedures. We try not to do any ablative procedures at this age. And we also look for the original cause by doing the CT scans to find out if there's any pressure on the nerve. And now we go to laryngeal webs. This is the failure of recanalization of the larynx. And 75% is at glottic level, most anterior with subglottic involvement. There are 4 types of increasing severity. Many are present at birth. So you do a flexible laryngoscopy, and you can always do a airway fill-in, which is also helpful to see the subglottic area also, whether it is extending there. Now, this is a child. You can hear the voice of the child. That's the kind of squeaky, birdie sound the child makes. And this is the web here, and it's extending into the subglottis, as you can see. So we did this case exactly 4 days back, and you know during COVID times, you could take all kinds of precautions and do it with the battle dress and do it. And the surgeons and the anesthetists, we sweat like mad because a lot of fogging also is there. And this child has been moved out of the ICU this morning and doing reasonably well. And we used a cold touch and made an incision here, and then used a electrical tube as a stent for 2 days. You can use the laser also. Oh, we used the laser. Sorry, we used the CO2 laser in this particular case. And today is day 3 of the surgery. It's a brand new case. So the other important pathology which is often missed is the subglottic hemangioma. You see, again, flexible fiber optic laryngoscopy is the most important investigation, and I keep saying, seeing is believing. But as a clinician, you must also look for other signs. So here you have the vocal cord, and here you have the mass in the subglottic area. And the differential diagnosis here, one is of course as a hemangioma, and the other one is you can also have cysts here, and the cysts could be iatrogenic because of intubation. Because one of the glands is blocked and you can get a cyst there. And these are the normal tracheal rings here. And you can have another condition called complete tracheal rings, which I'm not discussing today, which we have had some cases. And that's the subglottic hemangioma. Now, the real true advancement has come in this area. So this is a 2-month baby. I told you they come around 2 months. And the giveaway here is the child has got a hemangioma in the bird distribution. In the beard distribution. Sorry, let me go back and show you that. Okay, we'll run the video again. That's the hemangioma. This is after being given some medicines. At that time, they had given some steroids at that time, the neonatologist had given. So it is small, but then it can be as big as in this particular case, as you can see, and cause a lot of obstruction. But the magic treatment for this actually has been, I'll show you the beard distribution of the hemangioma again. So 50% of the cases have a hemangioma in that area. And of course, steroids do make it smaller, but the revolutionary treatment is actually propranolol or nadolol. And the options are tracheostomy, laser ablation, cryotherapy, sclerosing agents, corticosteroids, but the treatment we give these days is propranolol or nadolol, which probably has lesser side effects. We've got no experience on that. And there are some people who first use the CO2 laser and then use propranolol. It started off at 2 milligram per kilogram body weight or even 1 milligram per kilogram per day. And then it goes up to 3. And you are supposed to give it for 6 months. In one of our cases, we had to give it as long as 1.5 years. So there are always exceptions. If that doesn't work, you have an open excision. Then we come to a very, very commonly missed diagnosis. 1 in 10,000 to 20,000 births, rare. But by the time they're diagnosed, some of them die, or sometimes they go from hospital to hospital and ultimately have pneumonia, aspiration pneumonia, and die. This is because of the failure of the tracheoesophageal septum developing the rostral portion. And 6 to 12% of the tracheoesophageal fistulas 6% have a posterior laryngeal cleft, and 20% of cleft children have a agenesis of the esophagus or a tracheoesophageal fistula, both ways. And we have the Pallister-Hall syndrome, which we already showed you, and then it is present at birth. The child presents with symptoms at birth. That's what the star says. There is respiratory distress, fatigue, cyanosis, aspiration, pneumonia, and ultimately they will die. We have a series of about 10 cases up till now. It is extremely rare. And we do surgical procedure for this. And this is the surgical procedure we do. You do chest radiographs, you do barium swallow, do an endoscopy, very important, to see where the cleft is. This is the arytenoid, this is the arytenoid, this is the vocal fold spreader, and this is the vocal cords here. And you see it is going down, and there is 4 types. One which is at the level of the vocal cord, below the vocal cords up to the cricoid, and the other one is going much lower than that, that is into the cervical trachea and the thoracic trachea. There are 4 types that we have, and you can see this video here. You see that is a L-shaped one, which we are using to tell you how deep it is. That is the level of the vocal cords here. So no wonder the child has aspirations every time you feed. And they present around 2 months, and children who are grade 3 and grade 4 will present much earlier. And grade 1 may be managed non-surgically also. And what we do is the treatment is the timing and approach for surgical repair will depend on the severity of the symptoms, associated abnormalities, type of cleft. They are part of many syndromes also. In a small cleft, you can do conservative positioning and thicken food. And if fail, do surgical repair. You can give a gel-form injection, you do an open approach and graft into position, or an endoscopic approach. And very important for GERD control. And endoscopically, you do a 2-layer closure, sternotomy. Overall mortality is almost 43%. And type 4 clefts, the mortality is very, very high. And what is the advancement? The advancement is that we are doing these procedures without doing a tracheostomy. And that's an anesthetic challenge. Now about the subglottic anomalies. The subglottic stenosis, 90% of subglottic stenosis is usually iatrogenic. Very few of them are congenital. And failure of laryngeal lumen to recanalize, I showed you a couple of pictures earlier. It could be membranous or cartilaginous. And then if the subglottic diameter is less than 4 millimeters, then it's L1 stenosis. It's the third most common congenital airway problem. And SGS is considered congenital if you do not have a history of intubation. Now, there are some of them which can be dilated, and the endoscopic approach can be done. So what we do these days is we give radial incisions with a laser or with a sickle knife, and then use the balloon dilatation, where there's a fixed volume balloons are available these days. The ones used in cardiac side, similar to that, and then the dilated part soon after dilatation. And you take the time, and after 4 weeks, to check out if it's working. And there are some contraindications for using this. If the thickness of the web is more than 1 centimeter, if it is concentric, it may not work. Now, we are talking about advances now. So I want to talk to you about those children due to congenital subglottic stenosis for whatever reason, they require a neonatal tracheostomy. Can we avoid the neonatal tracheostomy? A neonatal tracheostomy is a huge burden on the family and attendant problems. So this is a very smart idea which came out from the ideas of Dr. Cotton and Dr. Seed, and it's called the anterior cricoid split. See, this is a neonate where incision is given, the transverse incision. It's a very short video, and you expose the thyroid cartilage here and make a long incision on the midline of from the superior part of the upper part margin of the thyroid to the lower part. And after giving that incision and defining the midline, you take a little bit of the ala of the thyroid cartilage, and now you see the incision here. Sorry, the video is a little long for neonatologists. They've been probably shorter. Here you are. We are putting sutures here so that for the tissue above the on the subcutaneous tissues. And this is the thyroid ala we are harvesting. We've harvested the thyroid ala, and then we'll use this as a distractor. We'll make a slit here very soon. See, we're making a slit in the thyroid cartilage, and you will see the endotracheal tube inside very soon. And we are taking the thyroid ala, measuring the thyroid ala, cutting it to customizing it. And after doing the graft measurement, we put the sutures, and the very picturesque way of describing it, we parachute it into the opening. After taking these sutures, and you'll just see the suture, this going like a cap and blocking that. So what we have done is, most of the subglottic stenosis problems is at the level of the cricoid. So you cut the cricoid in the midline, cut the lower part of the thyroid cartilage below the vocal cords, cut again in the first and the second tracheal ring. You give a nice long incision from here to here, and this is the thyroid ala which has been removed from nearby. You don't have to take it from any other part, like in the costal cartilage. Put it here, seal it, and then close. I think it's a very brilliant idea because you can avoid a tracheostomy and send the child home. That's the real advancement. Now, let's take one particular case here of a child presenting to the clinic from the pediatrician for frequent coup, history of intubation of for 5 days at age 15 age. Upon examination, we found an audible biphasic stridor, and then we decide to perform a fiber optic laryngoscopy. And let us see what we see in this particular case. The cat is already out of the bag. You can see the almost grade 3 kind of stenosis. Of course, stenosis we classify whether it's grade 1, grade 2, grade 3, grade 4, 0 to 50, 50 to 70, 70 to 80, and no opening at all is a grade 4 stenosis. And then you'll have to assess how thick it is. And based on that, you do this particular case, you can do either balloon dilatation may or may not work, but you can do an anterior cricoid split and thyroid ala augmentation. So we go to the next slide here. Now, intubation injury is very important. As a neonatologist, you have the opportunity many times that you need to do intubation, but then of course your ingenuity has resulted in a lot of non-invasive ventilation, which is very, very useful, not only initially to avoid a tracheostomy sometimes, but also following reconstruction of the airway. We do various kind of reconstructions, and after the reconstruction, there are problems. So as we wean off the child, take out the tube, this is very, very useful. And let's see one or two typical airway injuries that, injuries that we have. Oh, no video, okay, sorry. So this is the granuloma which is formed here due to the ingress of the tube. And if it's an emergency intubation or there are multiple intubations or a tube which is slightly oversized, then you have these problems. So this is a granuloma here, which we success. Unfortunately, video is not working. Otherwise, this was removed and the child became all right. There was no problem. And again, no video in this. Okay, here we have this particular case. You can see, again, this is an intubation injury. And I don't know whether you can see it there. Can you see this band here between the two vocal cords? This is one vocal cord, this is one vocal cord, and this is the band which is formed. And there's an opening here, and there's a little posterior stenosis here. And if you cut this, then it becomes established. But if the vocal cords are with the arytenoids are fixed, that requires much intensive treatment. So this is an interesting slide. I thought I'll put it for you. This was a study which says there's a 50% increase in risk of subglottic stenosis with every 5 days of intubation, and a 12% increased risk of subglottic stenosis with each additional day of sedation. You're all very enlightened neonatologists. I'm sure you try to wean the child off as early as possible, but it's better to keep this in mind. Although I must confess that the amount of injuries due to intubation in neonates is much less, not only because I guess neonatologists are well trained, also because the pliability of the larynx in these small children. We have children where we have had children intubated for as long as 3 months without any problem. That doesn't mean we keep the tube for that long. And there are other factors which can cause intubation injuries, like when the child is on steroids, where there's a lot of movement of the child, shearing stress on the tube, ventilator movement, etc. All whether the child is on hypotensives, whether various other issues, whether the child has got any infection, etc., etc. So it's best is to avoid, iatrogenic injuries to the larynx. We have a complete talk on intubation injuries, but then this is not the forum to talk about it. So it's better to prevent. And in conclusion, what I would say is seeing is believing. So flexible fiber optic laryngoscopy is the most important thing. And the other thing is that endoscopy is the cornerstone of all diagnosis, evaluation, and treatment. And it's aided by the technological advancements in optics, the beautiful pictures we get these days. And most of these cases, we operate off the monitor. And this is techniques, the anesthesia, most important. And I've left out one more important thing by default, not by design, is the post-operative care. When the child is operated for laryngeal stenosis and the child has got a stent inside, it really a big burden on the neonatologist or the pediatric intensivist, whoever is taking care of these children. They have to be on some kind of sedation, not too much of sedation, so that they don't move around, so that the graft doesn't get displaced, the tube is in position, the stent is in position, there's no shearing stress, and then getting the child slowly out of this weaning off from the ventilator. All these things are probably much more difficult and not as well defined as the surgical procedures we do. So my hats off to my care taken of my children post-operatively, and people like you, neonatologists and intensive care, are the people who do that. Imaging techniques, I told you, is supplementary, and you have to customize the treatment to suit the patient. And of course, oft-repeated thing is all stridor is not laryngomalacia. And to add to that, why endoscopy is important is sometimes 40 to 50% of these children do not have one, but they have two pathologies. And another major pathology which I have left out in my presentation is children with complete tracheal rings that cannot be confirmed, just like laryngeal cleft, unless we do a flexible fiber optic laryngoscopy. Now, what are the advances that has really come? One, in laryngomalacia, we have better understanding, and we now know when to intervene, when not to intervene, and what is the type of intervention that we need to do. Secondly, in stenosis, better training of neonatologists, better intubation techniques have resulted in lesser and lesser iatrogenic. It has really come down in the last 5 to 10 years, depending on each country's training of their neonatologists. Then the fact that we can avoid tracheostomy by doing anterior neonatal tracheostomy, by doing an anterior cricoid split with thyroid augmentation, which I showed you. Then the fact that hemangiomas, subglottic hemangiomas, almost most of them can be treated with propranolol is a major advancement. Otherwise, it was a difficult surgery in these small children. Then the surgical techniques have evolved. Basically, there are two types of surgical techniques. You either make the pipe wider by putting a graft and making it wider, or the narrowed portion, you cut it off, which is a resection. These are the basic two things that we do. Now, surgical indications are all well-defined, and the training is ongoing, and we have workshops every 2 years in our hospital. And this is a workshop where neonatologists, pediatricians, anesthetists, everybody joins, and it's an interdisciplinary workshop for better exchange of ideas. And I must say that all the work that we've done, 90% of the work we've done in the last 18 to 20 years has been free of cost, because we had about 60 to 70 lakhs deposited to take care. Otherwise, we would have never been able to build this, because cost and skill both are in short supply. And the main advancement is we've got into fetal medicine, and with fetal medicine, colleagues identify those children who have an upper airway problem, having a congenital high airway obstruction syndrome, and around the time of the birth, with the teamwork, we've been able to manage to keep these children so that these children survive, keep the children alive, and then so that all the effort that is done in these precious pregnancies don't go waste. And how did we do all these things? It's because of my pediatrician, neonatologist, anesthesiologist, colleagues of the hospital. The hospital has been kind enough to give us free beds. I must acknowledge that. It's a for-profit organization, but they've made a waiver for us. And I was lucky to talk about this in CENTAC, which is a Society for Advancement of ENT in Children in San Diego last year. And the topic they gave me speaks for itself. It says, building a team where no stadium exists. And I think that is my ultimate honor. Then we also did an oration in Pakistan in 2008, and we had a couple of Pakistani patients. And we've really, over a period of time, without the help of all my colleagues and my hospital, we wouldn't have been able to do. But the most important people are referring people, neonatologists, pediatricians, who had the trust in us. Thank you very much. Hopefully my patients are hopefully breathing easier now. And if there are any questions, I'd love to answer.
Abhishek?
Hello. Yeah. Can you hear me?
Yeah. See, mute all. Abhishek, only you unmute yourself.
Yes.
First,
Yes.
all the written questions, and then
Yeah.
subsequent can raise the hands one by one. We will ask the audience. They can straight ask question to our speaker. So I request all the participants to mute their video and audio now. We'll just clear off all the questions which has been posted in Facebook and everywhere. Then one by one, we'll take from audience. Over to you, Dr. Abhishek.
Yeah, thank you, Prashant. Thank you so much, sir. It was such a fantastic presentation. You really mesmerized all of us, sir. Wonderful, sir. And always the neonatal laryngeal disorders are always a very difficult area for a neonatologist. And it's always the ENT surgeon who comes to our help in such difficult times. So your vast experience in handling neonatal airway disorders, it really shows up in your presentation. Thank you so much, sir. There are a few very interesting questions. Can we move on to the question and answer session, sir?
Please do, please do.
Yeah.
I hope the latter half of the talk was visible, or it was okay?
Yes, sir. Yes, sir. It was all very clearly visible, except for very few technical glitches because we're doing on Microsoft Teams for the first time, the NNFK webinar. But your entire presentation was very clear, audible, and visible, sir. No issues, sir. Thank you so much. So I will move on to the question and answer session. There are a few very interesting questions. One is on laryngomalacia. How long the H2 blockers or PPI needs to be used? I think you already covered that. Yes.
We normally give it for 3 to 6 months. And basically, originally we were giving different countries. For example, in India, we tried to use lansoprazole, is what we use. And I found in Singapore and other countries, they were using ranitidine, but then ranitidine has its own problems. Now it's not available. So I think it's back to PPIs, although it's slightly an off-label recommendation in laryngomalacia. But there's enough evidence to show that it does help in these children.
Okay, sir. Thank you. The next question is, what best can be done to pair a Robin sequence neonate with recurrent life-threatening episodes?
So we have performed an exit procedure for one Pierre Robin syndrome. Not all of them require an exit procedure, but in this particular case, we thought that the child may have a problem. So what we do is we have the slides. Unfortunately, we don't have the time. But what we do is in this particular case, let me think, because we have the exit procedure, it was very difficult, and we thought we will avoid a tracheostomy by doing the exit. And the intubation was attempted by one of our best ever anesthetists. So she was using one of those, what do you call that, fillet with the tube, and she just got a glimpse of the larynx, which we showed through our nasal endoscope. And when it was done, unfortunately, there was a tear in the esophagus, so we had to quickly do a tracheostomy for that case. This is not the scenario always. So these children, usually what we do is we observe them, and if the obstruction is there, we again look for problems. They could also be having laryngomalacias, etc. Secondly, there are various techniques which were quite barbaric, which I did it when I was in Delhi many years back, soon after my graduation. We used to do stitching the tongue, anterior part of the tongue to the mandible with a wire. I mean, I think it was the most cruel operation ever. It was done in Sweden. So we are guilty of doing one or two. But these things, techniques are there. One is, of course, various positioning, etc. is done. Apart from that, we do mandibular distraction techniques is there with our maxillofacial surgeons, where they distract the mandible, and the jaw is becomes more forward, the mouth opening, and every time, just like the orthopedic surgeons have their techniques, the screw is tightened, and the mouth opening is enlarged, and the bone goes in that area where they've done the distraction. So that is what is done these days for Pierre Robin syndrome children.
Abhishek?
Hello. Yeah. Sir, this mandibular distraction technique, how commonly is it done, and how useful it is on follow-up?
Very useful. And I always, when I go for a wedding, I tell those people I'm coming again for the next wedding. So when you call me for a talk, I tell the neonatologist I'm going to come for another talk. So we will talk about Pierre Robert and mandibular distortion whenever I get the chance. But let me tell you, all of them don't require. Many of them we have done without distraction because the maxillofacial surgeons having sufficient experience in this area are not easily available. I don't do it personally, being ENT. I'm not trained in that, but it's an interdisciplinary thing. And we have done in the last, our center, by the way, is the only integrated interdisciplinary children's airway and swallowing center, which includes a gastroenterologist, pediatric cardiologist, the whole gang. And so the maxillofacial surgeon is also part of it. And we've done cases of mandibular retraction. The others have managed with positioning, special feeding techniques, etc.
Wonderful, sir. Yeah. There's one more question here again on Pierre-Robin syndrome. How do we treat Pierre-Robin syndrome with repeated episodes of aspiration?
Yes, so you must take the help of the swallowing specialist. That is the most important. They have very good techniques. Of course, some of the children land up with the pegs. In fact, we have a child now who doesn't even have usually Pierre-Robin syndrome. They've got macroglossia, they've got a cleft palate. Of course, they've got a small jaw. But in this particular case, the child just has a bud. Tongue is like a bud. So the child is still on peg feeds. So when these complicated cases are there, it becomes that. So the aspiration is a major problem, but there are very good techniques that our SLPs suggest, and the children can be managed till the time things improve. Maybe you have to do peg feeds.
Okay. There's one more question here by Dr. Archana Bilgi, ma'am. What is the outcome of speech in babies with laryngeal atresia post-surgery? Is a quote-unquote voice box present?
Okay, so laryngeal atresia is an umbrella term. It includes various grades. It starts off from webs only, which slightly thicker webs up to the subglottis, and some of the other cases I showed you. In fact, in the second case I showed you, I don't know whether I told you or not, there was absolutely no opening at all. And this child came to us, I told you, basically was breathing through a tracheoesophageal fistula till the pediatric surgeon could do a tracheostomy. So 6 hours the child was alive after birth, but then that caused some amount of cerebral damage. And we operated on the child. The child did well. And after 2 weeks had a seizure and aspirated and unfortunately died. So we'll have to assess the nervous function, etc. And sorry, what was the question? I'm just losing track.
Basically, post-surgery, what is about speech? Speech in these babies post-surgery.
Right. So the vocal cords are very rudimentary in these children, but then they have some amount of movement. And the first child which we did was about 13 years back, baby Krishna from Calcutta. That boy has got a rough voice. Voice is not great, but he is intelligible. We can understand. He's in school and he's doing really well. So voice is always an X factor. Even in the webs, sometimes we do surgically fine, but then the voice is not very great. So voice is one thing which is slightly unpredictable, but it improves. Intelligibility improves, but not the best voice.
Okay, sir. Yeah. And one more question. What is the smallest size of baby, weight-wise, that a flexible laryngoscopy can be done now in Bangalore or in India in general?
Oh, we are the smallest in our, this thing was, I think we've even done younger than that, even 1 kg we've done. I think we've done up to 1 kg children also, but what record I have here says 1.5, but off my head I remember. And there are very small laryngoscopes available. And then there is a technique to bypass this. So what we do is basically we do transnasal laryngoscopies. Okay. Now, if you can't do a transnasal laryngoscopy, you can do a transoral. So even if it is slightly larger, because the larynx is lying very high in these children, just behind the tongue, you can do a screening laryngoscopy very easily. Otherwise, 2.1 scopes are available, but they do not have a suction. So if you want a smaller scope, suction won't be there. If you need suction, then you need to go for a higher level of scope. 2.9 is what we use normally in our hospital, but then we have used it orally also to assess the larynx.
Okay. During my training in Trivandrum, in KIMS Trivandrum, we were fortunate to have Dr. Jaykumar sir and Dr. Manju. I think they were very valuable and I mean, similar to the cases that you have described. We were fortunate to be a part of a few of such cases which were operated. And yeah, I think, like you said, sir, around 1.52 kg baby. I think we must have done there in Trivandrum too, sir. Yes, sir.
I think transoral we've done in some definitely below 1 kg also. I mean,
Okay.
we can have multiple other problems, so prognosis.
Okay. There's one more question. Strider with failure to thrive. What could be the common causes?
Any obstruction in breathing, because the work of breathing means much more. The metabolic demands of the child as a child grows requires more feeding, and feeding is interrupted or disrupted, or they can have genetic choking episodes, cyanosis, where the feeding has to be stopped in between. So any upper airway obstruction, depending on the severity of that particular condition, could be only the laryngeal problem, or it could be a pharyngeal problem with incoordination of swallowing. These days, we are doing a lot of what is called a SPEECH, functional endoscopic evaluation of swallowing. That's another thing we're doing, because we've got an excellent speech and language pathologist. So these are all areas we get into over a period of time as your center becomes more and more busy.
Okay. And one question on vocal cord dysfunction. How will you treat vocal cord dysfunction is a question, sir.
See, bilateral vocal cord dysfunction, you need to investigate the child by doing a CT scan right from the base of the brain downwards to see what the cause. Arnold-Chiari malformation is one of the causes where appropriate treatment is given to take the pressure off. Then we have some techniques, usually in children, if it is unilateral vocal cord palsy, they have a weak cry and they may have feeding problems, and bilateral vocal cord palsy, they have a respiratory problem, but the cry may not be that low. And between the two, many of them improve over a period of time, and some of them may require a tracheostomy if the block is so bad and you wait. But then one of the operations that we do, because we don't believe in operative operations, which we do in adults, called as a chordectomy. They remove the portion of the cord. There are two parts of the larynx. One is the respiratory larynx and one is the phonatory larynx. So the respiratory larynx is, as far as the respiratory function is concerned, and the phonatory larynx as far as voice is concerned. So if the posterior part of the vocal cord is is removed, one vocal cord, that's a chordectomy, it doesn't affect the voice that much. At the same time, because it's the base of the triangle, more surface area is available, so the child's breathing problem settles down. But even then, we would not like to do as much as possible, because there is I would not do a destructive operation. I would do a cord lateralization, that is putting sutures from outside the neck into the vocal cord, move one vocal cord outside, and this is called the cord lateralization operation. And one of the techniques being popularized is by one of our Indian neonate surgeons, Dr. Neeraj Mathur from Delhi, Lady Kalavati Hospital, and it's been published in the International Journal of Pediatric Otolaryngology. He comes as a tutor to our courses, and I find this technique very, very useful, where the cord is lateralized so that you have more time for the for it to settle down. So good prognosis in those cases.
That's interesting. Yeah.
That would take longer.
Okay. Yeah. And what about unilateral vocal cord palsy?
Unilateral vocal cord palsy, basically feeding techniques you must do, how to feed the baby in such a way that the aspiration doesn't occur. But if aspiration is too much, unfortunately, you have to do a peg and a tracheostomy, you try to avoid it. But many of these cases, a large percentage of these cases improve. Some of them have the problem after a PDA ligation. And some of them, unilateral cord, this thing could be even post intubation, some kind of a pressure injury, etc. So again, we have to get all our younger people trained in good intubations and avoid intubations as much as possible. But children with multiple neurological problems, maybe you need to do a trach and then you do a peg feed.
Okay, sir. Yeah. There's one question from Janaki ma'am. How early can a baby with type 3 laryngeal cleft be operated?
I must first thank Janaki ma'am for supporting us for so many years. I mean, it's trust of people like her which has kept us alive and kicking. type 3 is very, very difficult to, they present much earlier and they are very difficult to operate. In fact, she has sent some patients to us, and type 2, going to type 3 we can manage, but type 3 actually you may have to go through an external approach, and the external approach has its own morbidities. So the longer the cleft, the the worse the prognosis. So that is the thing. But then protect the airway. When the child is little, has grown to some extent, then all these procedures become much easier. But it's a battle. And it also depends whether the child has got any other comorbidities. If the child has other comorbidities, the prognosis is poor. Otherwise, these days reasonably good. 60 to 70% of them can be sorted out.
Okay, sir. Yeah. There's one question from Dadet, sir. Since all striders are not laryngomalacia, how to counsel parents in absence of fiber optic laryngoscopy?
In absence. Unfortunately, there is no definitive alternative to fiber optic laryngoscopy, and I'm sure I've been requesting my ENT colleagues, and we've been holding workshops to train more and more people, because we have a childhood population, you know much better, below 18 population of more than 40 million, which is much more than many countries' populations. So obviously the children and neonates and the pediatric demand is so much that I think all of us should learn. It should be accessible and available. Now, having said that, you have to clinically see whether this is a simple laryngomalacia or whether it could be any of the alternatives. All that I'm trying to say in today's lecture, as far as the clinical diagnosis is concerned, there are other conditions which may not improve over a period of time. So if it's an uncomplicated inspiratory stridor with not too much of retraction, not too much of feeding related problems, definitely we can presume the child has got laryngomalacia and wait for some time. But then nothing can substitute a flexible fiber optic endoscopy.
Okay. Yeah, these are the questions that I had right now. Any other questions, Prashant?
Because yes, it's very important, because what happens is newly learn how to do a flexible fiber optic laryngoscopy. We get a basket diagnosis of laryngomalacia, tracheomalacia, bronchomalacia, and things like that. So to some extent, what happens is there could many times up to 20 to 50% of these cases can have what is called as a synchronous lesion. That means one is a laryngomalacia, and they can also have a subglottic stenosis, or they can have a cleft. Many of the cleft children also have laryngomalacias. And in fact, when we do the cleft operation, we try to operate on the child, and subsequent to that, because of the tightness of that particular area, we do releasing incisions as in laryngomalacia, so that the child doesn't land up with laryngomalacia following cleft closure. So synchronous lesions, more than one lesion is there, then it's very, very important to do a full endoscopic examination.
Okay, so that's a very interesting point. Thank you so much, sir. Any other questions, Prashant?
One more comment I want to make. I'm sorry, hogging the line.
No, yes, sir. Please, sir. Please, sir. Yeah.
Many times, what happens, I've attended a lot of pediatric surgery conferences. Many times, pediatric surgeons, excellent pediatric surgeons, take care of tracheoesophageal fistula, and they think their work has not succeeded because the child continues to aspirate. This is because about 20% of laryngeal clefts have tracheoesophageal fistula. So nobody looks at the larynx. So you miss that diagnosis, and you feel that you failed in your surgery, but actually it's another pathology causing the problem. So cleft and tracheoesophageal fistula, esophageal agenesis and tracheoesophageal fistula, they all have an association. So I think more and more of us have to look, and unfortunately, tracheoesophageal fistula can't even be definitely diagnosed. It can be suspected by a flexible laryngoscopy, but has to be confirmed by a rigid laryngoscopy, taking a L-shaped instrument, separating the arytenoids to see how deep the cleft is. So it's a misdiagnosis most of the time.
So for routine, all TF babies before posting for surgery, should we do a laryngoscopic evaluation, sir?
If it's a hospital like ours where we do it free, I'd love to see all the patients, but it may not be practically possible. But in case the child's, history suggests any of these things, definitely a laryngoscopy examination is so simple, flexible at least, you can suspect it, and then you can go ahead and check the cleft. And two of my cases, my own hospital, we had after closure of tracheoesophageal fistula, where the surgeon thought that probably he hadn't done a good job.
Okay. Very interesting, sir. I think most of the topics which we as neonatologists need to know in neonatal ENT, we have covered, and this presentation is really very valuable for each one of us. Prashant, any other questions?
Now we will take up questions directly from the participant. I think
Okay.
sir has been waiting. Sir, please, whoever has a question can unmute one by one and you can start asking the questions.
I just need 2 minutes of a commercial in between if you give me.
Yes, sir.
Please send patients who don't have money to us. We'll take care of them free of cost.
Yeah.
That's a really noble work which I've been doing, sir, since the last many years.
Namaskara, Raman sir.
Hey, it's a privilege.
It was wonderful.
Dr.
Bilgi,
Bilgi, in this area.
Namaskara.
Yes.
Chanagittu. I
Thank you.
learnt a lot. You are my guru. Yeah. It was beautiful. Yeah. Thank you. Bettiagana ಮತ್ತೆ.
Sure.
Anybody has a question which they want to ask, they can unmute themselves one by one, or they can raise the hands and then start asking the question.